What is going on? Hello, Yandong.
Yes, John,
Hey,
I
Yandong.
invite Tony to webcast this presentation.
How you doing?
I'm fine.
Well, good. You get to meet Dr. Goel.
Yeah.
Have you met him before?
Mm-hmm.
You have met him before?
Yeah. Last Friday
Oh,
in Shenzhen.
oh, okay. I'd like you to meet his associate, Abby Shah. Are you there, Abby?
Yeah, Abi is here.
Oh, okay. Oh, yeah. What do you mean? Wait a minute. What's going on? I'm confused. Are you in India or is she in China?
He's in China, I'm in India. John,
I'm confused. He
don't
says
be confused.
he said, "Hey, let me tell you what happened.
Yeah.
I have a webcast with a student from Dominican Republic that's interested in neurosurgery, and I do webcasts in Russia with Manuel Encarnacion. And I came to talk to Manuel Encarnacion, and into the room walks this Dominican in Russia." And I didn't even know he was there. He says, "Hey, John." I said, "What are you doing there?" He said, "I just got here to Russia."
Great.
Was that a good story?
Yeah.
Okay, I'll save it then.
Yeah.
Okay.
Hi, Andong.
Hello,
Okay,
Abi.
I'll be
How are
back.
you?
Nice to meet you.
Nice to
I'm
meet
fine.
you. Yeah.
Yeah.
So let us see now.
Yeah, let us see.
Maybe he's just come home from somewhere. So it'll take a few minutes to join.
He's coming in the royal carriage.
Yeah, John.
We gotta
Diwali here today.
we gotta get a picture. We had a dynamite webinar with Russia.
Which one?
Russia.
Okay.
They
You didn't
had
have the China one today.
yeah, we had one with Yandong last Saturday.
Oh, that was yesterday, right?
Yeah, yesterday.
Yeah.
Yeah, that's inflow temporal force approach type A.
Yeah.
Yeah, and you
But-
do a lot of neuroanatomy, right? You do many live dissections, Abby?
Yeah, I do. But right
Oh,
now, no time.
well, we had, I normally don't do them because of most labs are not set up correctly, don't have the right cameras and stuff. And one thing I'm seeing is you always have to have a commentator on the mic because the person doing the dissecting loses, track and people watching the section, they don't know what they're seeing. So it's really nice to have a second person.
Yeah.
I think. What do you think, Andon? You can
Yeah,
do
yeah.
both ways are fine. Both ways are fine. But we did more. Yandong, the video was really good. We tried it with Ike, but it wasn't so good. But he's setting it up now, I think, because we were taking a camera shot of the endoscope screen. In other words, we were taking, like a video of a screen, and you lose a lot. You do that. But anyways, he's getting it set up correctly. So we can correct directly from the endoscope to the Zoom.
Yeah, this is not a question in China because we have so many lab surgery of endoscopy operations, and we can directly see the screen. This is no problem in China.
Really? Oh, okay. Very good. Okay, I'll be back in a few minutes. Okay, Abby, I made you co-host. You saw that, right?
Yeah, I did.
Yeah, you can admit people there, like when the king comes.
I don't think you have? John, you've not yet made me co-host.
I didn't make a co-host?
No, I don't see it.
Okay, let me see here. Oh, yeah, I didn't. Right.
Yeah, now you did.
Okay. I'll make Yandong. Okay, Abby, are you there?
Yeah, just give him a few minutes. He's just
Yeah,
come
yeah.
out. Yeah, just he'll join soon.
Yeah, I was just going to say, there's no hurry. Don't worry about it.
Yeah, yeah.
Take your time.
Yeah.
Okay, let me. Oh, yeah, change your background. Okay. Yeah, I think, Abby, if we get the technology of televising the live dissection, it'll be more popular online. Some
I
like
think we just need a good camera, probably. A good
a
to
good
record
what?
from the, yeah.
I'm
Okay,
sorry,
the
I didn't catch you, Abby. A good what?
good camera to record.
Oh, good camera. Yeah,
Yeah.
yeah. It's, the thing is, a lot of conferences they include the live dissection, and then they'll say to me, "Okay, we got a live dissection," and then we go to the lab that's not set up.
Yeah.
And it's difficult. You don't want to see a surgeon just standing at the field
Yeah.
and then doing a dissection, cutting down through the skin, and that's all you can see.
The king
So,
has joined, John.
I'm sorry.
The king has joined. I just made him panelist.
Oh, okay.
Yeah, the king is here.
The king is here.
Yeah, John, I'm here.
Long live the king.
Thank you, John. Thank you, my dear John.
Okay,
I
very
send you
welcome.
my best Diwali greetings. Today is a very big national festival here in India.
Oh, really?
And
What is
I
it?
wish you, I send you my greetings and my best wishes, my dear friend.
Boy, you guys like to have holidays.
This is
Have so many holidays. How do you keep track?
a big one, but big one.
Okay. Okay, ready, Atul?
Yeah, I'm ready, John. This time a little bit, you know what? This is a
Okay, hold on. Let me introduce Abby. I'll introduce you first, okay? And let her introduce you properly. 10, 9, 8, 7, 6, 5, 4, 3. Good morning from Miami Beach, home of Neurosurgical TV. This is John Bennett. We have the king is back. He had a brief respite that he was bouncing around parts of the world. I don't know which part. He'll talk about it. But I'd like to have Abby give the proper neurosurgical introduction to Atul. Welcome, Abby.
Hi, John. Thank you. And let's begin another episode of Spinal Revolution. As I don't need to introduce Professor Goel, all of you know that he is not even he has revolutionized craniovertebral junction surgery, and now he's showing you the revolution in spine surgery. He is rightly called the king of webinars because, I think he must have the most number of webinars in the world probably, and also the most largest experience in a lot of skull base and a lot of spinal cases. Like in craniovertebral junction, he likes to say he has an experience with about 3,500 cases. So, whatever he says, it's from a huge load of experience and a huge lot of cases that he sees, and a lot of theories and hypotheses that he has placed are all true, and we see the clinical results in the patients, and it is really magical to see this. So without further ado, I will hand over the stage to Professor Goel, and today we'll be talking on management of OPLL.
Can you see my slide, John?
Yes, not full screen yet.
Now?
Yeah, perfect.
Okay, so first of all, let me wish you all very happy Diwali. This is a national festival in India, and most of the people in India are busy celebrating this festival, I'm sure. And I see several of my dear friends on the screen. And I wish to, as I go further in my journey in spine surgery, as I go further in my experience in this field of spine and this world of spine, I get more and more happier about it and more satisfied about it and more and absolutely convinced about what I'm talking about, because it is real, because it is the future, and because it is absolute, and because it gives new life to the patient. The operation which I am recommending are simple, they are safe, and they are strong, and they are there to stay. I have to say that whatever concepts I am going to present, I have present on several occasions, on several parts of the world, and many of you have heard them more than once. But because it is so important, because it is such a revolution in the field, I am absolutely have no hesitation to say that there is no problem in repeating what I am saying. So today I am going to talk to you about OPLL surgery, ossified posterior longitudinal ligament, and when it creates myelopathy and radiculopathy. It is an absolute last sentence, last word on spine surgery. They are difficult, they are dangerous, and they are potentially, absolutely, you can have a complication at hand, and you can have a bad complication. I'm not sure how many of you who are listening to me at this point of time have done OPLL related operations, but believe me, if you have done more than 10 and if you say I have not had a single complication, I may probably not believe it, because it is difficult. It is, nobody has really understood OPLL surgery. So to discuss this surgery on OPLL, I will have to go a step back in my discussion and first let you know the basic of what I'm going to talk to you about. I'm going to repeat my slides, and you, even if you have seen it 10 times or 20 times, don't worry, just see them again. My belief is, and my absolute conviction is, that in spine surgery, whether it is degenerative spine, whether it is OPLL related spine, whether it is disc-related spine, whether it is canal stenosis, whether it is cervical stenosis, it is compression is never an issue. Compression is never primary. Compression is always secondary, protective, and adaptive in nature. It is indicator of unstable spine, and it is an indicator of the need for stabilization, and it is reversible. Most important, it's reversible. You don't need to do decompression. You don't need to worry about compression. So these are the sentences which I have been talking about for quite some time, and many of you have heard them on more than one occasion. This is also a very dear slide of mine. Human body is in standing position, and all our muscles are located and focused on the back of our spine. And all of our muscles are located and focused on the facets, on the subaxial facets and on the C1, C2 facets. C1, C2 facets are unique, they are flat. Subaxial facets are oblique. Cervical facets are oblique in one direction. Lumbar facets are almost parallel facets. So if there is any weakness of the muscles which take care of our standing human position, they will lead to problems at the facets. If it is at the subaxial facet, there will be vertical, because the facets are vertical. It will lead to instability, and the facets will have a kind of listhesis, which is vertical listhesis. I will discuss about it. And if there is any weakness of the muscles of the craniovertebral junction, there is a circumferential, or the instability can be anterior, posterior, and central. So there can be a circumferential instability at the craniovertebral junction. And in the subaxial spine, there is vertical spinal instability. So when the weakness of the muscles which make us stand and focused on the facets, when they become weak, there is a subtle listhesis, or the facets, there is a vertical instability at the facets, and there is a telescoping of the spine. There is a telescoping of the, like you zoom your camera, there is a telescoping of the spine. And this vertical instability, I've discussed on earlier occasion, is the basis of spinal spondylotic disease. It is not the disc which is the problem. It is not the disc degeneration or disc space reduction or disc water reduction which is an issue. It is the muscles focused on the facets which lead to vertical facetal instability. That is the point of genesis of spinal spondylotic disease. So when the weakness of the muscles of the nape of the neck occurs, there is a central instability. Most important issue is, one is acute instability and one is chronic instability. In craniovertebral junction, there is a phenomena of chronic. The instability can be for 10 years, for 20 years. And this instability results in secondary reparative mechanisms which are in the form of Chiari malformation, syringomyelia, basilar invagination, and a host of other issues which I have discussed earlier on this platform. So this instability I like to call as chronic central or axial instability. And whatever we know about pathology of craniovertebral junction, wherever we are doing decompressions, are not primary, they are secondary, they are protective, and they are reversible. In this series of cases, I have also put spinal deformities on degeneration, OPLL I have put, and Hirayama. So I will be discussing about OPLL in this presentation. So facets are the issue. Facets are the fulcrum of all movement. Facets are the strongest point of movement. Facetal bone is the strongest. Its vertebral body is not strong. Transverse process is not strong. Spinous process is not strong. It is the facets which are the strongest. So weakness of the facet can lead to listhesis. We all know that. Weakness at the vertical instability at the C1, C2 facet can lead to basilar invagination. We had discussed this about 25 years ago. Listhesis at C1, C2 as the cause of basilar invagination. So basilar invagination is the problem. Listhesis or instability is the issue, and stabilization is the treatment for basilar invagination. Decompression is not the treatment. This is what we have discussed. So basilar invagination is not a fixed anomaly, which everybody had at least 20 years ago. Everybody thought that basilar invagination is fixed and decompression is the treatment. For the first time in the literature, we said transoral decompression is not the treatment. Instability is the issue and stabilization is the treatment. So this is basilar invagination type 1, where the facet of C1 is listhesis over C1 over C2. There is listhesis is the issue, stabilization is the treatment. This is now everybody in the world recognize that transoral decompression is not the issue. However, type 2, when the facet of C1 is dislocated posterior to the facet of C2, there is no problem at the atlantodental interval, no compression, but instability is the issue and stabilization is the treatment. Even when the facets are in alignment, presence of Chiari, syrinx, assimilation of atlas are all secondary, are all protective, are all indicators of unstable spine, and stabilization is the treatment. So C type 2 and type 3 we have labeled as these are chronic. These are chronic atlantoaxial instability. It is manifested by secondary alterations like Chiari, basilar invagination, syringomalia, platybasia, and a number of os odontoideum, bifid C1, bifid C2, clipal file abnormality, assimilation of atlas, and a host of number of issues which the current literature describes as pathological are all secondary to chronic atlantoaxial instability, which are central and type 2 and type 3 in nature. There is no compression by the odontoid process. There is no dural or neural compression. It is diagnosed on telltale evidences which give the information that this is unstable and this needs stabilization. So chronic is the issue, chronic. Now, degenerative spine is also chronic when their muscle weakness does not occur in one day. It is a chronic process. Injury of the muscles can lead to acute disc herniation. That is acute. That is a different entity. Chronic atlantoaxial instability can lead to an entity called central instability. And if you see so many issues which I have described here in this cartoon, basilar invagination, short neck, short spine, bifid, os odontoideum, kyphoscoliosis, torticollis, C2-3 fusion, all these entities are considered today by the world literature as pathological. And for all these entities, decompression is the treatment. My idea is now getting absolutely clear. Like for Chiari, decompression is a negative phenomena. Syringomalia, atlantoaxial instability is the cause. If there is only C2-3 fusion, nothing else in the spine, C1, C2 fixation is necessary. If there is only basilar invagination, nothing else, there is C1, C2 fixation is the treatment. So there is a big potential for a complete revolution in craniovertebral junction surgery. So there is no hesitation on my part to say that we have demolished transoral surgery from the literature, and we have also demolished now foramen magnum decompression surgery. We have not yet done it, but it is eventual and it is absolute. Now, a little bit about degenerative spine, because it is relevant to the subject of OPLL. Degenerative spine anterior surgery is a most important surgery. The whole world does disc removal, osteophyte removal, OPLL removal, corpectomy, discoidectomy, multi-segmental fixation, and things like that. And we were also doing for several years. And now I'm saying that this kind of decompression from front is, for these problems, is not a good form of treatment. This is what I have already talked. I have said that these problems that you see on the images, these compression are not primary. Ligamentum flavum buckling is not primary. Disc space reduction is not primary. They are secondary, and they are related to multi-segmental spinal instability. All the muscles are focused on the facets. Weakness at the facets lead to instability of the spine. There are not many muscles attached to the disc, and we have said on an earlier occasion that disc is divine, disc can never go wrong. So degenerative arthritis of the craniovertebral junction I have discussed earlier, and this was the first article in the literature where we had said that instability due to arthritis is an issue and stabilization is the treatment. Reduction in the interbody space, interfacetal space, buckling of the ligament, osteophyte formation are not primary events. Whole world today does decompression for these kind of problems. I am saying that this decompression is not a treatment. Instability is the issue and stabilization is the treatment. Osteophyte formation. Now this issue of bone formation, which is also relevant in OPLL. This bone formation has been universally considered to be a pathological phenomena, and for this kind of osteophytes in front of the odontoid, over the odontoid, in front of the odontoid are related, and decompression is the treatment, the whole world. But what we said for the first time in the literature, that these osteophytes are indicators of unstable C1, C2, and stabilization is the treatment. Decompression is not the treatment. Other thing that we said, and also related to OPLL, retroodontoid pseudotumor. Sometimes there is ossified, sometimes there is calcified, sometimes it is cartilaginous. And this we identified to be similar to osteophyte and similar to OPL. And we said that this is an indicator of unstable C1, C2, and stabilization is the treatment. Decompression from front or from behind is not the treatment. So this kind of bone in front of the odontoid, behind the odontoid process, retroodontoid pseudotumor as it was called, we said that it is equal to osteophyte formation or OPLL in the craniovertebral junction. It indicates an unstable spine and it indicates the need for atlantoaxial fixation. There is no role absolute for decompression from front or decompression from behind. And this is, as you can imagine, a complete revolution in the field of craniovertebral junction and retroodontoid pseudotumor, which were being removed by the whole world by transoral, by all kinds of approaches. Even we said about this cyst, if you find unstable spine, you have to stabilize. This will disappear as soon as in the immediate postoperative period. This kind of bony tissue, cystic tissue, pannus behind, these are not primary phenomena. Even bone formation behind, you see there is a defect in the bone. These bone formation or cyst formation or pannus formation is always an indicator of unstable craniovertebral junction, unstable atlantoaxial joint, and stabilization is the treatment. You see, this is bone formation behind the odontoid process. This indicates an unstable C1, C2, and it needs stabilization. This is what we have said, and I have discussed this on an earlier occasion. So retroodontoid pseudotumor, no question. Retroodontoid pannus in rheumatoid arthritis, the whole world was doing transoral surgery for removal of this. We said that it is due to vertical collapse, buckling of the ligament, stabilization, distraction is the treatment. So facets we have understood for craniovertebral junction. For subaxial facets, instability at the facet is a very real thing. Instability at the C1, C2 facets we know, but subaxial facets we did not know. Reduction in the joint space, buckling of the ligaments, buckling of the disc space, osteophyte formation. It is absolutely clear that it is due to listhesis at the facets, vertical spinal instability, osteophyte formation, and all these things are secondary. They are protective and they are indicators of unstable spine. Any form of decompression, we have said that it is a negative form of treatment. So vertical facetal instability is the real issue. Earlier, we have talked about introduction of intra-articular spaces for degenerative spine, distraction, reduction, and fixation. And this technique is now being done in several places in the world. Decompression, this was the first time in the world literature where decompression was not considered as an option at all. And this was a secondary form of decompression. And we did several cases at that time. Decompression was not the issue, stabilization was the issue, and arthrodesis was the ultimate clinical outcome. And we published this on several occasions, and this paper has also become popular. For lumbar canal stenosis, also I introduced these kind of spacers. This stenosis is not a primary phenomena. This is not any problem with the disc. It is due to vertical instability, as I have discussed on degenerative spine in my earlier presentation on the subject. So we introduced these distraction spaces. So compression has been the issue in spine surgery, and decompression has been the treatment in spine surgery for several decades. We came to a point where we said that there is not even the need for distraction spaces. Instability is the issue, and only fixation for degenerative spine and for lumbar spine. there is no role for decompression. So more recently, I published this article. You can read the title, Muscle Weakness Related Spinal Instability is the Cause of Spinal Degeneration and Spinal Stabilization is the Treatment. And as you have heard me talking about degenerative spine, these are the degeneration. You stabilize, the osteophytes will disappear, the patient will instantly recover. And this is another case, you stabilize, there is no need for any decompression from front or from behind. And as I have talked about this subject in an earlier presentation, for degenerative spine, for lumbar canal stenosis, for cervical stenosis, for disc herniation, instability is the cause of problems and stabilization is the treatment. It is not neural deformation or compression, but instability is the cause of symptoms in degenerative spine. What are the indicators? Now in spinal, when people talk to me about degenerative spine and they ask me, what is the critical issue in degenerative spine? Understanding of which segments are unstable. That is the issue. And this article of mine will give you some indicators at which level are unstable. For instance, in this patient, there are 2 levels which are problem, but I have done 4-level fixation. Same slides I had shown in my earlier presentation. You see the whole thing has gone, but why 4 levels? Why not 2 levels is the issue. You have to clearly understand that it is not just radiological correlation, it is clinical correlation, and it is also intraoperative correlation. Also, we have said that atlantoaxial, also this is the first time in the literature we have discussed that atlantoaxial instability can be associated in multi-segmental spinal spondylotic myelopathy in addition to subaxial or without subaxial instability. So even when there is no compression, there can be a central instability of C1 and C2, and you have to do C1, C2 and subaxial fixation as a fixation construct, not as a decompression construct. Lumbar canal stenosis, also we said that it is not a stenosed canal. It is, and you see the beautiful title which I gave this in Neurosurgical Focus, Role of Stabilization and Futility of Decompression as Treatment for Lumbar Canal Stenosis. So this is what I had said. Similarly, this bone formation in front of the cord, osteophyte formation, these are not a problem. They are divine intervention. You stabilize and the osteophytes will disappear. And this was my beautiful article, which you will like to read. And there are several cases which I have shown in an earlier presentation. Now I come to my subject as ossification of OPLL. Now, what I have said is that OPLL and cervical spondylosis, same is the cause and same is the treatment. Like when there is central instability, you can get Chiari, you can get syringomyelia, you can get basilar invagination, you can get clipal file, you can get so many problems. Similarly, in chronic subaxial spinal instability, you can have reduction in the joint space, osteophyte formation, and in a host of patients, you can get OPLL or ossification of posterior longitudinal ligament. If you read the literature on OPLL, nobody has really or clearly given an indicator as to what are the causes of OPLL. Many people have said that there are some dietary issues, hereditary issues, regional issues. They have said that it is more common in Asian countries, not in Western countries, and things like that. And everything has been said, but the issue of instability has never been really considered as a generator of OPLL. So my concept is clear and my concept is positive and definite that OPLL is due to an unstable instability or vertical spinal instability. As far as OPLL is concerned, it can be segmental, it can be multi-segmental, and OPLL, various forms of treatment have been described in the literature. All forms of treatment have been decompression, either from front or from behind. And some people resort to stabilization as they think that multi-segmental decompression can lead to unstable spine. Like if you do multi-segmental laminectomy, you can have an unstable spine later in the day. If you do multi-segmental decompression from front, you can have unstable spine later in the day. That is the reason people do stabilization. Stabilization has always been considered as a potential of instability. That is the reason of stabilization. This is what the current literature is saying. And we also had quite an experience of decompression in my own historical perspective. For the first time in the literature, we described oblique corpectomy for OPLL. This was the first article. And this was the picture in my article on the subject where we did this kind of oblique corpectomy and decompression of the disc. This whole thing was removed. The OPLL was removed and decompression was done. So we were familiar with decompression. And when I said about oblique corpectomy, I said that in such an oblique corpectomy, you don't need stabilization because you are leaving a part of the bone behind. But now my concept is completely changed and different. My concept is that instability is the issue. Initially, as I started my journey on OPLL, like this is the OPLL, I started doing intrafascial distraction and spacers. And you see how the compression has been relatively reduced. And most important is that there is no decompression. This distraction I used to do earlier. I have to also say that in OPLL, instability is not so marked as it is in degenerative spine. Instability is there. Instability is positively there. You will never see fusions at multi-segments in OPLL. They are active joints, they are unstable joints, and they are the cause of the whole problem. This OPLL, this bone formation is secondary, it is protective, and it is potentially reversible. I am working on this reversible issue on OPLL, and still I am waiting for more longer-term follow-up. But for this kind of issue, where the whole world is doing decompression from front or from behind, or laminoplasty, and some people do some kind of stabilization, I have recommended. Earlier, I recommended this kind of spaces. But now I recommend that there is no need for even secondary decompression in OPLL. This is the OPLL, and this is the compression. Do not decompress from front. Do not decompress from behind. It is an unstable multi-segmental issue, and stabilization is the key. And I resort to this cannulus transarticular fixation of the facets. This kind of fixation is remarkably simple surgical procedure. I can do 5-level fixation in 20 minutes. So it is remarkably simple. It is remarkably strong and stable. And it is, in several cases which I have done cervical cannulus technique, never I have found a screw coming out or things like that. It is solid, it is stable, it is safe, and it is long-standing. For this kind of OPLL, decompression from front or decompression from behind is the norm in the world. I am saying that do not do decompression. Just do this cannulus technique of fixation and see the magic. A magic that you have not realized in any kind of decompressive surgery. So this kind of OPLL, you see what I have done is only fixation, no decompression, and absolutely magical clinical outcome is the result. And that is in the immediate postoperative period. Also, many people ask me that how will this compression be? It will be causing symptoms. Why don't you do decompressions right away? Why don't you do fixation and decompression? I'm saying that decompression is not necessary. I am saying if suppose you have done this Camille's technique of fixation, and your patient has not recovered, you can do decompression from front or behind at a later date. Your once stabilization is done, decompression is possible. But what I have to say is, over the several years where I am doing only fixation, I have never resorted to any kind of decompression at a later or a second stage surgery. Fusing of the facets or Camille's technique of fixation has something unique or something magical in it. And this magic has to be seen and has to be realized, and this magic has to be understood. My concept over the years is absolutely, do not worry about cord compression. Do not even think about cord compression. Just come and stabilize this and see the magic of the treatment. This is another patient, multi-segmental OPLL, dangerous. If you come and remove multi-segment from front, there are more than 50% chances of serious complications. If you do laminoplasty from behind, there are huge chances of not having any kind of clinical outcome. My feeling is absolute. If you do only laminectomy, which is the gold standard treatment for this multi-segmental, you have not done anything good to the patient. You have probably harmed him. You have probably done made him more unstable and more weaker than before. Let me see if I can. I'm not sure if you can understand this language, but
नीचे करो ये वाला नीचे करो.
and this what I'm showing is immediate post-operative. You see now he's sitting up. He was not able to sit up before the operation.
Okay. अभी ऑपरेशन से पहले घुटने पे मोड़ो जितना मोड़ सकते हो.
And I can only tell you that
अभी सीधा करिए.
this kind of a magic.
दूसरा पाँव.
You see now he's on the wheelchair, he's moving.
घुटने पे मोड़िए. अभी मुझे हाथ उठा के दिखाओ ऊपर.
This is in the immediate post-operative period, a kind of magic that we have never realized in OPLL surgery. You see, this is the whole world will either come from front and either come from behind and do decompressions. No decompression and magic is the clinical outcome. This is another case of multi-segmental issue, multi-segmental OPLL. And here only fixation is done and only stabilization is the aim. Now about atlantoaxial joint. I have realized that atlantoaxial instability is very frequently associated with subaxial instability. And you have to do atlantoaxial stabilization in addition to subaxial stabilization. But more recently, I have realized that you can do C2-3, like this is C3-4, you can do C2-3 transarticular fixation, and you can avoid fixing the C1 facet, and you can preserve the C1 rotatory movement. So that is an alternative form of C1, C2 fixation. The sum and substance is that instability at multiple segment, instability at the atlantoaxial joint as well is the issue. And you have to do atlantoaxial and subaxial stabilization. And this is real, and this is solid. If you see the joints, if you see the facets, they are the problem. These are secondary. This is the muscle weakness is the primary issue, and the problems of the facets, osteophytes at the facet, erosion of the joint of the facets are the issues which are very commonly seen. So this is another multi-segmental OPLL, and I am sure the consensus will be laminoplasty and all. But I have to tell you, my dear friends, that that is not the good form of treatment. A revolution has been made, a clear revolution has been made in OPLL surgery. You have to do, I'm not saying you do C1, C2 fixation like that. You have to do C2, 3, and subaxial stabilization, quick operation, safe operation, solid operation, and a very, very simple and lasting operation. Let me see what this. I am not able to show you the video, but video is not necessary. You have to hear, you have to just believe in what I am saying. This is another case. You see this OPLL patient has come with remarkable. This is in the immediate postoperative period. So he was carrying a stick. You see here, stick he is carrying. Now there is no stick in the very immediate postoperative period. And if you have to see a happy patient, you have to do. This is the what I have done. This is another case of OPLL at a lower level, but you will realize that I was doing this kind of fixation earlier in my career, but now I do C2-3. If you also realize that there is no real compression at C2, 3, 3, 4, 5. So you will focus at only C4, 5 and 5, 6 and 6, 7. But I have done multi-segmental stabilization. Why I have done multi-segmental, why I have included atlantoaxial joint is the issue which I consider as the most important issue in the treatment of OPLL and also degenerative spine. You see, this is the problem. This is the OPLL. This is not for decompression from front, not from decompression from behind. And if you know, and if you are clear, the whole world recommends decompression. You try the C1, C2 fixation and subaxial fixation. Which levels to fuse is the issue. And you have to read my article on this subject. This is another case of OPLL and no decompression, only fixation. So over the years, I have got several patients and several articles on the subject where I have mentioned, and I have to also tell you that not one patient of mine has ever worsened. Not one patient of mine is only little bit happy. All my patients are remarkably happy. If you see this was my data in my publication. Majority are remarkably happy. And, this has only to be understood, believed, or followed. So atlantoaxial and subaxial cervical spinal stabilization, can it revolutionize the treatment of OPLL? My answer is clear. My answer is definite. My answer is positive. And my answer is only one. Yes. And without any doubt. So atlantoaxial instability is the cause of high OPLL. Atlantoaxial instability is also and frequently associated in OPLL in subaxial OPLL. So atlantoaxial instability is very frequent in OPLL cases and has to be handled. So this is the paper which I published first, is only fixation the treatment for OPLL. And then I published my experience of 52 cases where I said that only fixation without any kind of decompression is the treatment. And now my experience is more than 120 cases and without any doubt. And when I say that in my 120 cases, all my patients have improved, many of you or most of you will not even believe. And if I say that most of these patients have magically, not if I have to say all of my patients have magically improved, you may not believe. And I have never resorted to any kind of decompression after my initial fixation. So these are the C1, C2 and subaxial fixation. This is another case of OPLL where I have done C1, C2 and subaxial fixation. This is another case of OPLL. You see beautiful, quick and solid fixation. And as I have told you now, even in the presence of evidence of C1, C2 instability, I do C2-3 fusion, subaxial C2-3 fusion. I avoid incorporating C1 facet in the fixation construct. And this is an alternative kind of C1, C2 fixation technique. And subaxial fixation, transarticular, no decompression for such a massive compression, as you can see, massive. So don't ask me this question. You see massive compression, that why don't you do decompression simultaneously? I am saying that it is not necessary. I am saying that it might never be necessary. I am saying that it might be a negative operation. I am saying that decompression is not an answer. So can atlantoaxial and subaxial fixation revolutionize the treatment of OPLL? Is an absolute yes. So some more cases I'm showing you. You see this OPLL and subaxial fixation, multi-segmental Camille's technique of fixation without any decompression. And here is the patient which I will rapidly show you. You see how he's walking. And I'm not sure if I can show you the walking here. See, he's walking much more stabler. Unfortunately, this is much more stable, much more better. You see the gait, and without any hesitation, I have to say that he has got a new, brand new life after surgery. This is another case of OPLL, and I have done, you see, this is a long. And if you ask me about what happens to the OPLL after a few years, I'm still working on that phenomena as to only fixation. What will be the result? I'm seeing some changes in OPLL, which I will be describing in my article, which is in publication at present, and you will have to wait for my answer to that question. So this is another patient of OPLL, and here is the person running around. Unfortunately, the video is not coming. But I have to say that you see this kind of bone fusions that you are seeing. Even in the bone fusion, I have done fixation. My recent work says that evidence of bone fusion, evidence of new bone formation, evidence of osteophyte formation, evidence of OPLL formation are all evidences of unstable spine, and stabilization is the treatment. So this is another case of OPLL. Let me see if I have some. So this guy is also smile. You can see his smile in the immediate post-operative. He's walking in a much stabler, much better, much happier fashion than before. And you can see this gentleman. So let me go further. Here is another person. You see multi-segmental OPLL with disc-only fixation. And this guy is walking much better than before. See, this is the preoperative image. And this is the immediate postoperative where he's trying to get up from the bed. And I have to only tell you that he's very happy and very satisfied with whatever has happened. I don't think I'm able to show you the intensity of improvement after surgery, because these videos have been given to me just now before the presentation. I have not even seen them. But I have to tell them that they have got new life, they have never been reoperated, and they have always shown remarkable or magical clinical recovery. Other thing is retroodontoid OPLL or pseudotumor. This is also an indicator of unstable C1, C2. They can be associated with subaxial OPLLs on a very frequent situation. And you need to do C1, C2 fixation as well. You see OPLL in this case. This is clearly a basilar invagination, little bit of an os odontoideum. This is an unstable facet. And you see this OPLL. There is no question that this OPLL is second, and this is, I had done, you see, this is distraction, reduction, and fixation. And this is completely a different. So my observation is that CSF or water or bone formation or fat formation in the spinal canal are all protected. They are all similar in their function as naturally protected indicators of unstable spine, all these three. And they are indicators of need for stabilization. For instance, Hirayama disease. In Hirayama disease, on flexion, there is a fat coming in the MRI. And this fat will disappear after stabilization. This fat is an indicator of multi-segmental instability like bone, like external syringomyelia, like syringomyelia. So water, fat, and bone are all indicators of unstable spine. They are not a problem. They are solutions. They are protection. You see there is fat here, fat here. They are indicators of instability, and they are indicators for need for stabilization, and a magic is the clinical outcome. So this is another patient of Hirayama disease where I have done multi-segmental stabilization. So chiari malformation, syringomyelia, basilar invagination are all processes, Hirayama disease, related to unstable spine. And that is the revolution which I am presenting before you. That revolution is that all these things are due to unstable issues in the spine. They are not primary, they do not need decompression, and they need stabilization. This hand in Hirayama disease, you do anterior decompression, dural decompression, and all those things have been described in the literature. But you see the magic of hands in the immediate postoperative period, such a magic, I have a feeling that it is not possible in any kind of decompressive surgery. So can decompressive laminectomy become historical for OPLL? My answer is absolute. My answer is yes. Like transoral surgery, will anterior spine surgery find space in the history book? My answer is yes. It is dangerous. It is potentially complex, and you can have complication following surgery, and it is not necessary. So these kind of surgery can certainly be done. So there has been long journey of degenerative spine, OPLL. So from only decompression to only fixation, this is, in my view, the journey of OPLL and degenerative spine. So this concept that compression is never primary and decompression is never the issue, never the treatment, in my estimation, it is absolute. Do not have any doubts about it. Do not think twice. If you have to think twice, you should come to me and you will be my guest, and you will, I want to show you what I have to show you. So thank you very much, my dear friends, and I hope you will try to think about this magic. I hope you will try to go beyond what you are used to, and I hope you can get a new magic in the treatment of this clinical entity. Thank you very much, my dear friends.
Thank you, Atul. Yeah, you know, I hope the panel uses this platform. This is the best time in history in medicine, Atul, because of this platform. All these people are able to interact with you about your presentation. This is just fantastic. Okay, Marcos, Abby, I guess you'll be, can you moderate Abby?
Yes, John. Dr. Marcos is here. I've just promoted him to panelist, I think. Dr. Marcos?
Yeah, I'm here.
Hello.
How are you?
Hey,
I'm
Marcos,
good.
how you doing?
Nice to have this
Yes.
wonderful lecture from Professor Atul Goel, and I saw in person his magic in spinal cervical procedures and neurosurgical procedures. So just seeing what he does, we can believe that the main problem of all of this disease is really it's really a problem of instability. We can see that, and fusion is the only choice. Thank you, Professor. But one question that I already told you at that time, why not, if you were there near the pathology, to do a decompression? Okay,
No.
you stabilize, and then you decompress. Why not?
No, it is, you know, it looks very real because you are already there, you are near it. You can just do laminectomy in 1 minute. But my concept has been so strong, my concept is so positive that it is not necessary, Marcos, to do decompression. And I have also told you that over the years, if some patient is unsatisfied or is not satisfied, I can easily do decompression at the second stage. But none of my patients has ever returned with an unsatisfied face and with complaints that I needed any kind of decompression, either from front or from behind. Mohammed, what you are there, Mohammed?
And do you think, Professor, that compression in future brings fibrosis to that region and other problems together also?
Marcus, it is not necessary to do decompression. It is not, it is, laminectomy and bone decompression is not mandatory. It is not necessary for any kind of, decompression is not necessary. Compression is not the issue. That is the revolution. You see, fixation and decompression, many people have been doing in the past as well. Fixation, they do fixation because they think that decompression can lead to an unstable spine. Multi-segmental decompression can lead to instability later in life. For laminectomy, they can produce deformities, they can produce kyphosis. This was the concept, which was earlier also. But now I am saying that decompression is not at all necessary. And it is a negative form of treatment. Marcos.
Can I say
Okay,
something?
thank you, Professor.
Yeah,
Thank you.
Mohammed.
Hello, Zaid. How are you? Happy festival. Wish you all the best. Always.
Everything okay?
I think Marcus has to go again to India. You haven't changed him completely.
Okay, thank you.
Marcos, you are invited again to India, okay?
I will go to learn
I will make some more
100%.
workshops with you.
Yeah, it's been amazing lecture. Thank you so much.
Thank you.
Very,
Mohammed.
very new concept. I have small experience, about it. Intraoperatively for the OPLL, they don't seem as unstable like the degenerative. But what
You are muted, Mohammed.
Can you repeat that?
Yeah.
You're muted. Repeat the
Yeah,
question.
you hear me?
Can you repeat? Yeah, repeat what you said.
Okay. So I said intraoperatively, it doesn't look as unstable like in degenerative, the segment that is ossified. But the adjacent segment above it and under it, I feel it's completely unstable. I'm not sure about it. I don't know if you agree with it.
No, my feeling is, when there is bone formation, when there is OPLL, when there is osteophyte formation or evidence of bone fusion, those segments are the most unstable segments. Those segments, the natural protection is coming more heavily. And those segments have been fused because they were more unstable and they needed more protection. And nature comes in picture and stabilizes. You understand, Mohammed? So it is not that the segment adjacent is less unstable, but they are more unstable. And you need to stabilize those segments, and also segments where there is no bone formation or anything may also be unstable. So you have to identify, that is the main thing, which segments are unstable and which segments need stabilization is the most critical issue in OPLL surgery.
And that's why I plan to come to India again to
Yes,
get this point.
you have to come again. Yes.
Yeah, today I did the L5S1 listhesis, and she will go home. She wants to go home today.
Very good, very good.
Oh,
Arjun,
thank
you
you.
are there? Yandong. Yes, Arjun.
Yes, sir, I'm here, sir. In fact, sir, we all have been very fortunate to have witnessed all such cases, all miracles in your OR, sir. And what I can say is it's all in those finer details, all those finer steps, sir, which probably we as youngsters need to learn from you in your OR, sir. That is what I can say. That is all what makes a difference. Definitely, it's all about the concept that you are raising, but those finer details. So, yes.
Thank you, Arjun. Thank you. Enjoy. And how are you?
Wish you very happy Deepavali as well, sir.
Thank you. Thank you. Yangdong?
Yeah, I'm here.
I can see you.
Yeah. I'm very nice to meet you again. What I want to say is I still remember the patients you operated on during last lab surgery workshop. The patient with OPLL presented with remarkable recovery immediately after surgery of only fixation without any decompression, which strongly supports your beautiful concept. And as I have said to you so many times, I will strictly follow your principles in my future practice. Thank you.
Thank you, Yang Dong. I've heard that you are doing some beautiful dissection, and I want you to continue them. And my best wishes to you. I know John is supporting your concept. John?
Yes.
John,
Yeah.
thank you
Yeah.
for a beautiful dissection Dr. Yang Dong is doing. I heard, and I'm sure he's making your platform more wonderful.
Well, Atul, a lot of labs don't have the right setup, so we're working on that to get the setup down. Correct, the video and the audio, everything, but we're working on that. And the next webcast is Saturday, correct? Next Saturday.
Yeah.
8 o'clock. 8 o'clock.
But maybe next Saturday, not the lab dissection, only a presentation of the anatomy of astral-temporal facial nerve. And on next Saturday, I want to show you the lab dissection of cranial vertebral junction.
Yeah, and Atul, I like to see more interaction between China and the rest of the world in neurosurgery. We welcome it. We welcome it, and we could learn a lot from each other. Okay.
Yang Dong, I will look forward to watching you. But don't do it next Saturday, do it Saturday after that, because next Saturday I may not be able to watch, but I want to watch it Saturday after that, craniovertebral junction, okay?
Next Saturday?
Next Saturday, don't do it because I will be busy. Do it after that, okay?
Yeah. Next Saturday, okay.
The king,
Thank you.
The king has spoken. If you violate his rules, you may be beheaded.
But if I do dissection on afternoon, John is sleeping.
Professor Goel, I'm telling John because we're gonna have in my town in 20 of November, Professor Bin Shu and some Chinese friends, and we make a day like you did there in New Delhi for me, and I'm asking John to broadcast it to worldwide. Many surgeries in one day. It's good format of teaching.
Yeah, we'll speak after. We speak after. So,
yeah, we can speak about it.
Okay, to wrap it up, anybody have any parting words they'd like to say? Okay, thank you very much.
Happy festival. Happy festival, Abi.
Thank you, and happy Diwali to all of you. It is a very big
Bye-bye.
Bye-bye.